we have for a long time struggled with really having very many treatment options at all for Parkinson's. I mean, for Huntington's disease. Sorry,
That's
I
okay.
am. Yeah, it tells you. I see a lot of Parkinson's patients, we care no less about our Huntington's folks. So, but yeah, so and that's been for decades was really the toughest thing, and maybe in that way it's not that different from where we were with Parkinson's, say 40 years ago. And so there'd been some evidence in the past that this drug called tetrabenazine, might be helpful, especially for the involuntary movements that are such a hallmark of Huntington's. And while it had been sort of available for a long time in Europe as sort of a orphan drug, if you will. It was very hard to get in the United States until just not quite 10 years ago when it finally was approved and brought to the U.S. specifically for Huntington's disease. And that was really the first drug for Huntington's. And tetrabenazine works by reducing and inhibiting dopamine activity in the brain, specifically in the circuit that we call the basal ganglia. And that's kind of like it's like our automatic transmission, our autopilot. It's what sort of lets us keep moving, keep walking, and without having to think left foot, left foot, right foot. It's also what lets us just sit and be relaxed and keep all our muscles in balance without us having to think about, well, I got to have my hip muscles tense and my back muscles tense and my chest and where's my torso right now? Well, and so when that system is out of balance, then we have trouble with movement. And if it's out of balance in a way that looks like or that acts like there has been a reduction of the dopamine side of things, you get Parkinson's. Well, if it's out of balance in sort of the opposite direction, where the areas or the circuits that are input by dopamine actually are overactive and out of balance that way, then you get excess movements. And one of the most classic ones is Huntington's chorea. So those are those sort of involuntary little movements, and then that happen, and that start out subtle, but can be quite troublesome, quite hard to ignore, or quite overwhelming even sometimes. And so what we realize, and this is oversimplifying things. It's not as easy as just more dopamine, less dopamine. It would be great if that was the whole thing, but working on that dopamine balance is really valuable in getting control of that side of the motor side of Huntington's, and working it in other ways is important in balancing movement and other movement disorders. So the problem that we had, even though we're so grateful to have a drug like tetrabenazine finally available for people with Huntington's, is that not everybody can tolerate it. It can be very sedating. It is actually metabolized or cleared through your liver and through your body fairly quickly by most people. So you have to dose it usually 3 times a day to get good balance. But I've also had patients that have had to dose it maybe 4 or 5 times a day.
Wow.
So that's that's a lot, especially when you're dealing with Huntington's, where sometimes, well, we're a little more, we could, because of the Huntington's, one can be a little more impulsive or a little more, a little less organized. So having something you have to take that many times a day gets even more challenging. I would, defy most anybody that you picked off the street to go from not taking something to taking something 4 times a day. That is very hard, even if it's just for a week of antibiotics. None of us is good at that. So.
Even under normal circumstances.
Yes, exactly. I'm not good at it, I'll tell you that. So, I don't know if I should admit that. No. No, I will happily admit that. It's very true. So, so while the principle of tetrabenazine seems to work very well, because of the way it's cleared and it sort of gets into your bloodstream pretty quickly, peaks, and then dips right back down. To try to get a right middle ground, you've got high spots and low spots in the medication. And every time you hit that high spot, well, you're more apt to have side effects. Sedation is the most common. Low blood pressure, which sometimes that and sedation go kind of hand in hand. And also, we'd seen, not just in the Huntington studies, but historically when the drug first was developed, that some patients really had aggravation of depression symptoms. Mm-hmm. And with that already a concern in Huntington's, that certainly was not ideal. And so, well, where does this new drug come in? Deuterated. So that's all we needed was one more syllable on the name of a drug, right?
Right.
It's a very important double syllable. So there's a process called deuteration, and I won't get into the pharmacochemistry very deeply because, frankly, I don't know that I'd be satisfied that I explained it correctly.
Yeah.
And for our purposes, it's not so important exactly how it's done, but it's more about what it does. Right. So by adding this little extra chain to the tetrabenazine drug, it changes how quickly it's metabolized, so it stays more level in our bloodstream. It changes how quickly it breaks down into these other active ingredients, some of which presumably are the ones that can lead to low blood pressure, the worsening of depression and those things. And what you get, or at least the aim of this, is to get a kind of a kinder, gentler drug of, that has the best of tetrabenazine, that minimizes and hopefully really eliminates maybe some of these unwanted effects to cut it for people with Huntington's. And so what we've seen, and there aren't officially, most companies are not, they're not really allowed to say, to do direct comparisons, or they don't, not excited to do that. It's sort of a risky thing. If you're trying to develop a drug, you want it to look as clear cut as anything, and then sometimes side to side comparisons can be very confusing. So, but then we do have some data, and I'm going to I'm going to read that off to you. Just bear with me if I get lost mumbling looking at a page, but okay. The idea here to kind of give you an idea of, well, okay, so why is this new and special or better? So there have been a few different studies looking at kind of indirect comparisons of tetrabenazine and deuterated, and There's one called Tetra HD and another one called First HD, and they both came out in favor. When they looked at the results, they both came out favorably for the deutetrabenazine, and they were on the side effect profile particularly. So there were a lower incidence of more moderate and severe adverse events. So the things that would make you not want to take a drug, or where you were trading quality of life in one area for quality of life with a side effect. So in those areas, there were lower rates overall of discontinuation between deutetrabenazine and tetrabenazine. So you were more likely to be able to stay on the drug long term and enjoy the benefits of the drug. And you were less likely to have to back down on the dose as you were titrating up, as you were building towards your optimal dose. Or have to hold a dose or two because, oh gosh, this really knocked me out and I don't want to take another dose until I feel normal again. This was quite, so those were some important differences. And let me just see here.
So what is the actual effect of the deuterated molecule? Is that somewhere I heard that was a heavy water molecule?
It is. So it is. It's like a water. It's sort of a, yes.
So does that allow it to be like a time release?
Right. So they say this sort of deuterated, when you add this heavy water molecule on, that it's supposedly it's 10 times more stable than a typical carbon-hydrogen bond. So if we're getting into the chemistry.
The chemistry, yeah. I was just curious to know that.
And then that, sort of that makes it much more stable in the bloodstream. And let's see, I think I'm just so.
And is the dosing less as well?
And I'll show you that it's close. It is probably a little bit less on average. It's so you may be able to get, I think, a slightly lower total daily dose, but the biggest thing is that you're able to tolerate the dose that you need. I think is really the idea. So maybe I can sort of show you here. And I don't know if the camera will quite let it show, but
potential benefits, yes.
Yeah. And see here, well, this is sort of the typical, this hash mark line is the typical, pharmacokinetic absorption graph for a drug like tetrabenazine. And what adding that heavy molecule does is it both slows the peak time, but and then stretches it out. So there's a thing we call area under the curve, and that's how much drug is actually, that's actually what, how much drug is in your system. And if it's, these two graphs may have the same area under the curve, but here you've got all this drug here being used up very quickly.
Yep.
And probably causing side effects. So, whereas with this line, what you get is that drug is now here.
Yep.
Lasting longer, it's giving you more benefit over a longer period of time.
Right. Good graph.
Yeah, that's pretty straight. I don't. On my screen, it comes out. It looks like it's in its mirror image, so I don't know. Hopefully, it doesn't.
I have you up front and center so we can see your face.
Okay. Look at my screen, and everything is backwards.
There's a switch on your Zoom that you can click off the mirror image. I had that same problem. Dr. Samantha, have you been taking care of HD patients and also obviously movement disorder patients for how long now?
Yeah, so I've been, so I've been a movement disorders neurologist since 2000, or I finished my fellowship in 2000. So,
Okay.
about
So you've seen a lot of change, haven't you?
yeah. So I mean, yes.
Mm-hmm.
And thankfully all for the better. I think it's um, always the most frustrating thing with treating Huntington's has been that it's that helpless feeling that we had when we haven't had much to do, or we had to borrow drugs from psychiatry that were really, really difficult to tolerate. And tetrabenazine was a big jump forward, but it's still, for a lot of folks that still aren't able to tolerate that. And I think this is a huge step in the right direction, because we know that the drug itself, what it does, is very valuable for our patients, and then it does it in a way that is, it's sort of a gold standard drug in that sense.
Yes.
Where I think kind of the way levodopa is in Parkinson's, or L-dopa is in Parkinson's. It's kind of the core molecule, and most of the drugs that we use there are we're either imitating dopamine and the effects of L-dopa, or we're trying to augment the effects of L-dopa.
So in Huntington's, it's low dopamine or high dopamine?
It's in truth, if you looked at the actual levels of dopamine, they're probably not terribly out of balance, but because of the loss of cells in what's called the caudate nucleus, which is a very important, you can think of it as a node in a circuit. And because that area is losing neurons over time, we lose the control or the balancing effect to the rest of the relays in the brain that are, in truth, are both motor but also cognitive and emotional. So they do play a role in why might there be more impulsivity or more forgetfulness or changes in personality sometimes. Well, because obviously Huntington's isn't just about the movement. For a lot of folks, there are many other changes, and sometimes even those changes are more prominent or cause more disability or more trauma, if you will, than the chorea does. But at its core, what we're trying to do with a drug like tetrabenazine is try to help rebalance the rest of the circuit by using chemistry and receptors. So, and I'm glad you asked that, because it isn't just not enough or too much. It's really a balance and an interaction thing. And so this gives us a way of countering the imbalance from not having enough activity out of that caudate nucleus. So, we've had diagrams of this. We call it the basal ganglia, and that's our autopilot, our motor control circuit. And and it started back in the 70s. It was a sort of had 5 or 6 nodes and different relays between them, and it was complicated. It was complicated enough that it had us still asking each other questions just looking at it, in how it worked. And every year we add one relay or another relay, or we discover that, there's a relay that goes between these 2 spots that we never knew about, years ago. it is, it's just, you have to think of sort of this incredibly layered and complicated sort of system of feedback loops that when everything is working perfectly, we function, that's what allows us to act like us. And it just takes, if just one spot is out of tune, or not functioning correctly, it has literally millions of implications.
Kind of like the electrical system in our cars.
Yes, like a very, very exotic electrical system. But yeah, where suddenly one day you turn on your windshield wipers and your lights go off. it just makes no sense to us, but somewhere in there's some circuit that's close to another circuit. And
do you have a research lab there, Dr. Samantha?
We don't in-house, but we work with the good folks over at ASU in their motor control lab, and their the Biodesign Institute. For clinical trials, I'll work with my colleagues over at Barrow, Dr. Schill, Dr. Miguel et al., and over at the Banner Sun Health Research, Dr. Sprecher, and then of course Dr. Adler and Driver Dunkley and Shaw up in Scottsdale at Mayo Clinic. So we are sort of we're an oddity or at least a rarity in movement disorders. We're a private practice group, and while we think it's important, and we are still active in aspects of research, our main focus is clinical care, and so we all have our little areas of specialty.
Right. So will you be doing any participating in any of the new clinical trials coming up?
Not so much directly the drug trials, but we may be participating in some of the family history, the informational studies, and helping recruit for those. We certainly will be helping to recruit with our colleagues around town for clinical trials as they are opening up for Huntington's. So we're just to say, if you come see us, we'll still actively help you search for those, even if you don't necessarily,
So are you doing the Enroll HD?
So we may begin taking part in that as well. I know it's been ongoing, and we're just working out. It's interesting, how quickly that can get complicated, but it's not that hard to do. I think it's just a matter of us getting on the same page with the sponsors and seeing if that will work for them. So
kind of designating a coordinator, maybe.
Yeah. Sort of. So just see if basically we're just going to figure out if our staff if we have the staffing to meet what their guidelines suggest.
Yep. I think they'll probably work with you because they need more people,
Okay. All right. Yeah. In fact, I'm happy to go to talk with anybody that's on your contact list too. So
Are you encouraged by some of the new research that's happening for HD?
Yeah, certainly. I think it's a little bit similar to what we've seen happen in Parkinson's too. Is that even the way we look at what the disease is or what's happening in their brain has changed drastically. We're looking at drugs that may reverse protein buildup and, and cell damage. And that's really where the future is going to be. It's right now as helpful as, deutetrabenazine may be, it's treating a symptom, and we know it's not reversing the disease progression or the damage. And that's really where research is targeted. And so there are, is there a role down the road for gene therapy? There's certainly a lot of study going on with that. It would seem to make sense because it's a well-isolated, well-known, well-recognized gene. The hard part is, yes, does replacing it, can we show that replacing that gene with the normal, with with a shortened exon, does that then correct biologically what's happening, what's leading to breakdown in the cell? Or is it like what we're discovering in Parkinson's now with, with some of these, there was a story about the chemotherapy drug a year and a half ago that enhances protein clearance so that clearing out the protein that may build up in most, really in maybe sort of the common link in a number of these progressive neurological disorders. That what we call apoptosis or cell death. That's maybe driven by a breakdown or an alteration in sort of the cell maintenance and cleanup and recycling areas.
Now, did you work with Parkinson's study group in your Parkinson's work?
Yes, yeah.
Irish Olson?
Years, yes, yeah. So, I was most of the sort of the bigger studies, as a fellow, and in the first 5-10 years of my career, we were one of the main sites for the PSG, and while we hadn't been in a Huntington study group site, we certainly have worked with the members quite a bit. Yeah.
Oh, I know what I was going to ask you. I was going to ask you about the botulinum toxin therapy that you do. Can you explain what that is?
Sure. So, and while unfortunately there are the applications in Huntington sometimes are a little bit limited for it, but there certainly are some very valuable areas where it may be helpful. But botulinum toxin has been around as a medical treatment since the late 70s or early 80s, and it really is a purified, very dilute form of the protein that's part of the toxin that the botulism bacteria makes. But unlike with botulism, bless you, unlike with botulism, you don't ingest it, and that's so you don't get it. You don't get a systemic spread of it, but we inject it locally, and what it does very well is it blocks communication from nerve ending to the muscle, so it can reduce spasm and pulling. So sometimes, other than chorea and Huntington's, patients get more rigid and they get stiffer. Their necks stiffer and their bodies get, and you think it's very hard to, it can be even difficult to try to get clothing on and off, or to even sit on a toilet. And so in some cases, injecting certain muscles with botulinum toxin may help them to relax. It takes a few days to begin, and usually the effects can last 2 to 3 months, maybe even a little bit longer. And the other area that it may come up in as potentially very helpful is in patients where, say, drooling has become an issue, because of whether it's a swallowing issue or a change in saliva output. But it turns out that botulinum toxin also is very effective at inhibiting secretory glands, so sweating and drooling or saliva being the kind of the sweating, mucus, saliva being the kind of the main ones. And so that can be helpful there.
How about for spasms?
Yeah. So again, right. So those patients that just where it's not so much about the chorea, but they get contractions, they get cramp spasms, foot, calf, anywhere. We can use it in those situations, much like we would sometimes with someone who maybe has had a spine injury and they have spasms, and can be very helpful with that.
My son has that actually.
Okay.
Yes.
Yeah, and those are, I mean, they're tough because it's not just disruptive or it makes it harder to do things, but it hurts.
Yeah.
And we can help people. We can help the people we love eat. We can help them with a lot of things, but we can't make them not hurt. There's no way to help with that when you're sitting there. So to have things that can help with spasms, that's.
We're trying to find someone in our local area here in California that will help him with this, and we've just had a really hard time finding someone.
Huh. Yeah. So. There's sort of a number of specialties that now use botulinum toxin. I think for our purposes, the big two are kind of obviously neurology, but then also physiatry, so the rehab physicians. So sometimes it may be helpful if you're having trouble with one specialty or one area finding someone. It's in some areas, for whatever reason, you'll find that it's the physiatrists that do all the injecting or that. And I think, of course, these things should just be, do you need it or don't you? But sometimes it's, insurance gets in the way, and it's
exactly.
well, it's not, this diagnosis.
And especially if you're on Medicaid or,
Yeah,
that's a problem.
It can be difficult, but usually, I guess that's the best I can say is usually with enough, with some well-written letters and explanations.
Yeah, that's what we're doing right now.
Yeah.
Lots of
painfully no
documentation, doctor's notes, things like that.
Yeah, it can be really frustrating.
Are you doing deep brain stimulation?
We do. We've been doing that. I've been involved with that since 1999. We haven't been involved with any cases for Huntington's. The group I work with on the neurosurgical side is Barrow Neurological Institute here in Phoenix. We have an excellent surgeon. I know that Dr. Hauser in South Florida has published several cases, or has had several cases that have seen relief of symptoms, and so I think it's still relatively early, though. I know his first case was probably published. Gosh, it may have been 10 years ago.
Yeah.
But it was very late at the. This is sort of one of maybe two or three, and it's still something where I think if tetrabenazine and these other things are not aren't tolerated, aren't available, aren't practical for some reason, it certainly is something that may be worth considering. And I think the best results tend to be for the chorea, and we still would have to say that as far as we know, we aren't changing. It isn't yet something that might be changing the course of the condition.
Probably for certain circumstances you would need that.
Yeah,
Well,
absolutely. Yeah.
gosh, we're running 45 minutes already. Can you believe that?
It always goes flying by, I
It
think.
does fly, and you're so great to give us this information. If somebody comes to your clinic, are there social workers available to help with certain things?
So we don't have social workers on staff, but we have referrals to social workers.
Okay.
Sarah's also a great resource to help connect people with those. We're
Yes.
very fortunate in that we have while we don't have maybe the big clinic or the university sort of resources, we have a lot of wonderful connections, and
Good to know.
to get people plugged in to various groups within the community as needed. So.
Well, I just would like to thank you so much for your time today and for this wonderful information.
You.
For pitch hitting too.
No problem.
Came to our rescue. So thank you so much. And I do want to thank PMD Alliance again, Sarah Jones, for allowing us to use this platform and offer up this wonderful opportunity to see super duper fantastic doctors like you. So thank you so much.
Thank you very much.